And we're back. This is the Dental Guys live at the Academy of Osseointegration 40th anniversary meeting in Seattle. Wes, it's been awesome so far. It's been controversial, which is what we hoped. And now we get to kind of continue the conversations.
I love controversy, and I love when we can reconnect with colleagues that have really taken the young clinicians and really showed what is possible if you do take evidence-based dentistry and take it to the next level.
Yeah.
And so John, introduce our guest.
Yeah, so it's been a couple of years. And you know, so this morning we were at some of the corporate forums just listening to some of the speakers. And Dr. Armand Bedrossian, welcome back to the show.
Thanks for having me.
Was here. We got to hear a great lecture. And not just saying that. I mean, we were kind of rolling around some of the corporate forums, and we were like, man, this guy's bringing the high-level stuff, which I think the last time we talked, it was like you were finishing residency. You were just kind of getting rolling and hitting it hard. And
scan paths and stuff, and your buddy was
super
publishing.
Nerd stuff, which
it was
we
amazing.
Love. We love it.
It was amazing.
Yeah.
And so I think, what we wanted to talk about, just to kind of really piggyback a lot on what you were, because, Wes and I have been on a lot of the same sort of full arch journey that you've obviously been involved with in terms of what is the best workflow. And as you said, I'll let you speak more about this, but, digital workflows is all the rage, right?
Yeah.
It's all over the place.
Yeah.
Everybody wants to talk about it. There's a lot of stuff that's really sexy.
Sure.
And then there's some things that you kind of have to remember, and we're all very familiar with, like the good and bad of Instagram. I'm just going to start it with that you can show a beginning and an end of a case, right? Here's where we started. Here's where we ended. I used photogrammetry, right? And that's so sexy.
Yeah.
But when it comes into what really goes into a workflow such as that,
wow.
You spoke a lot about just if you compare and contrast the old to the new, the analog to the digital.
Sure.
Talk through a little bit about kind of some of the evolution of that. How you started. What are you doing now?
Yeah.
What would you tell clinicians that are sort of thinking, man, should I jump into this? What do I need to be thinking about?
For sure. Well, first of all, thanks for having me. Last time we spoke, I was still in residency, and what's funny is a lot has changed. And when I always start off with my presentations, I always start off by saying that digital is cool, digital is sexy, but if you don't have a solid foundation of analog principles, it's just, like my third slide today, right? The software is only as smart as the person in front of the screen. So if you don't know why you need to have the STL DICOM, what STLs you need, how you're going to superimpose them, the software is kind of useless, right? So you have to...
Did we pay him to say this?
Yeah.
I know.
Because this is right in
I mean, but it's facts. I mean, you could always outsource it and not understand any of what you're saying, and then assume that things just miraculously work out. But no, if you're really doing it yourself, you need to know, be organized, understand the analog steps, because it's the same exact steps, but sometimes perhaps you might say, okay, instead of 5 appointments, let me do 3, because you can combine steps.
Yep.
But at the end of the day, each step is still there. What's funny is, when I graduated after I saw you guys last time, I'm obviously more involved in the lecture circuit, and what's people always ask me, you're 7, 8 years out, what the hell do you have to teach, right? And really what I think my niche that I found is I went to University of Washington. We had no money. It was a state school. We learned a lot of traditional techniques. Being a millennial, I learned a lot of video games, digital workflows, and understanding that the science really is pushing, especially in the last 8 to 10 years, piggybacking off the gold standard of traditional techniques. So my niche in speaking, and hopefully portrayed that way this morning, was let me bridge the gap with the 30-year-old vets that have done tried and true techniques for 30 years and say, hey guys, this is the science that you've been following. This is the science that the technology is following. And I think in 2025, you can adopt ABC. Yep. And I'm talking to the younger clinicians saying, hey, don't be naive. Digital technology is not a magic bullet. It doesn't all of a sudden mean that you can omit saliva and double core technique for tooth dentistry, and you don't have to worry about scan path or what have you. You have to follow some fundamental R&D principles, and then you'll be able to be predictable. But God forbid, Bluetooth goes out, laptop crashes, you promise the patient teeth, you got to know traditional things to fall back on.
Absolutely.
And so that's kind of what I try to do, is bridge the gap between the two generations, and hopefully the science shows that today you can do certain things within limitation. And that's kind of what I helped, to show this morning.
And I love that. I think that, that one thing is not true true, and that is that you can't do the digital without the analog, but you still can do the analog without the digital. And
100%.
that's interesting because we have to remember that if we're going to start somewhere, we have to start with what always works.
Yeah.
But let's talk about, okay, if you understand, assuming, which is a big assumption about understanding the analog. We know that's one of the huge pitfalls right now. But let's say you've been doing that technique and you feel comfortable for today's discussion. What are some of the things that with the newer digital workflows, we've been hearing a lot. You know, we had Mark Ludlow on the last 2 years at this. He's done a lot with trying to develop predictable full arch digital workflow. And there was first the discussion, okay, photogrammetry sort of came out of nowhere, really, I feel like. It was like a couple of years ago, it's like, bam, all this stuff's here. But then we also had things happening with scanners and different new techniques using new topographies, things that we can do that we can attach to scan bodies. You know, so which of those things should we be looking at? How do you compare some of that?
Yeah, the one thing that I want everyone to know is that they all work, but the question is defining what work means, right? So under the clinical significance of umbrella of whoever you're speaking to, the audience, right? So since, you know, prosthodontists, we're talking about what is the restorative or prosthodontic clinical acceptance for passive fit in full arch dentistry. And classically, it's 150 microns. Lately, like I showed today, some newer articles are saying that it should be really 100 microns to be accurately within the realm of acceptability. And when you look at all of the benchtop studies, in vivo studies, whatever it is, between intraoral scanning, ligating scan body, which is funny because in 2018 when we spoke, Ryan, my good friend's study was saying that you don't ligate with floss, but now we're talking about ligating with resin when it comes to those flags. And then talking about a reverse scan technique or photogrammetry or what have you. So all of these techniques have been shown to be under 100 microns. Now, the other variable or curveball to throw at it is that there's variability within the different scanners you have. So if you say you have RevX start is 84 to 118 microns, well, you say 118. If 100 threshold is the new threshold, that means it shouldn't work. Well, 118 were the scanners X, Y, and Z that didn't work. But for Trios 5, it was 84. And so if you understand that there's variability with the different scanners, with what you're doing. There's variability in the scan path. There's variability in the scan body you're using. There's variability in the algorithm of iMetric versus PIC or what have you. Then, you know, it behooves you to do your research and understand what your demographic is and what you're going to use.
Yes.
I mean, but they all work.
There's a certain amount of like clinical experience that leads to a certain, like, I'm going to accept. You know, the American Dental Association says that 100 microns fit for any type of crown is acceptable. However, you know, at this point in my career, I don't feel like that's acceptable. Sure. You know, and so I want you to talk a little bit about why that. Even today, you talked about how things feel. How screws feel. Even how you were talking about the maintenance and even seeing what 80 to 150, the difference in those two things mean. And why is it that we chose 100 now versus 150? We're talking about, you know, this is minuscule. What about it?
Is it because of zirconia and the lack of
is it because of these new products?
The
I think so one thing that's interesting to learn is, or to know is, okay, we know about the shrinkage in PVS, the expansion in stone. Every step of the way, from the, you know, the dry field to the impression technique in PVS to pouring it in stone, the setting time to everything had a calculated measure of clinical acceptability for the traditional way of making a crown or making a master cast, right? So if you look at it, okay, so we're arguing the definitive impression technique, right? So we're saying, okay, photogrammetry is sub 10 microns. Great. And then what are you going to do with that information? Now I'm going to go ahead and print a prototype. Okay, well, printing is another variable that has polymerization shrinkage. And then I'm going to add tie bases to it. Well, then now you're going to go ahead and have a 30 micron cement gap for the tie bases that you're going to cement. So who cares if you got 8 microns at the first step? Now you're somewhere between 80 microns or whatever it is, assuming your laboratory followed the 3D printing protocols of that resin, assuming the wash time was correct, assuming that they cemented on a model, not freehand cementation.
Well, right? There's so many too that, you know, you've not printed a model.
There you go. Yeah, exactly. So why 100 and not 150? I think it's just because we know that the technology is much improved with precision versus the stone model workflow.
But what clinical significance does 100 have over 150?
how can I argue nothing? How can I argue that it does? Because for 30 years before I was even born, they were doing this stuff.
That's exactly right. And my point
so it's
being
just
is
acknowledging that the technology's better.
I
though.
think what they're
guess
trying to do is just move the flag back by saying, hey, guys, since the technology is catching up or being better than traditional, why don't we go ahead and move the goalpost a little bit over to make sure everybody's being as meticulous as they should?
Yeah.
Because you can get sub 100, which is hopefully basically pointing towards the direction of perfect versus then the smudge of 160. I mean, who cares about 160 versus 150? You know?
Right.
So I think that's what it is.
I mean, a few years ago, we were listening to Conrad and a very talented technician,
Jack Morano,
and all them talk a little bit about like even how we should be if we were doing cylinder-based zirconia prosthetics, metal cylinders, that we're picking those up in the mouth, and which gave us better trueness. And,
100%.
And now I just don't see that that's necessary with some of the things and paths of journeys along the way, the things that we can incorporate.
Yeah.
Now, if you're talking about these different workflows and the accuracy of them, it's possible to get excellent accuracy. If I want to maybe gear this toward people who are, again, I'm trying to think of apply this to the most people that are potentially listening to this.
Yeah.
If you've got people that are doing I would say a lot of full arch or comfortable. Again, we're assuming just assuming they are comfortable with the analog. I want to talk about the practicality and the actual day-to-day with some of the newer workflows, okay? Because there's a lot of costs involved with some of these.
Yeah.
There's some things we could skip maybe, but there's some things we also add. There's some factors of just workflow of the day, depending on where you're practicing and are you in the same building or the same room. So let's talk about just from what you've been doing, right? What are you finding from an efficiency standpoint, from a cost benefit? Is it photogrammetry? Is it scanning with luting scan bodies together? Is it RevX? What are the things that you think people should be saying, hey, I should be looking at this to implement this into my practice?
The first thing I'd say is let me let you know I'm a private practitioner solo in San Francisco. I bought a general dental practice 8 years ago, and I'm slowly converting it to the pros that I want. In any workflow today, you can pick and choose whatever you want to do. You want to in-source everything and have a mill, a printer, ExoCAD software, and do everything from A to Z yourself, you're more than welcome to.
Do you want to have a life?
Yeah, exactly. Yeah, exactly, right?
Right.
Now, but if you're efficient enough, you can do it, right? So, for instance, for me, again, I'm speaking for myself. I was trained to do everything from pouring stone to waxing up an Emax crown to spruing it, casting it, going ahead and aerobraiding off the whatever stone. Now I forgot because it's been so long. But aerobraiding all that up and doing the post processing for Emax, right? And now all of a sudden I could just go ahead and design instead of waxing up on my hand on ExoCAD, or maybe even now future AI where I can make a crown design in 10 seconds and then outsource the milling for $70 with Alien Milling or whoever it is and choose my zirconia I want. So you can pick and choose whatever you want. For me, what I've done in my practice is I choose to have ExoCAD because I like to have my hands on in the design, whether it's a smile design for a wax up prototype, whether it's a tooth setup because I have Modja and all these other fun tools just to play around with for a prototype that I can 3D print. I have an in-house 3D printer. I don't have a mill. I outsource my milling. So all my definitive restorations from single unit to full arch is outsourced. That being said, I have a life, right? I'm designing crowns for single unit posteriors in between hygiene patients and what have you. I'm, designing prototypes or flippers or whatever it is for me to in between patients. And I'm not staying till 8 o'clock at night. I got 2 kids. I'm leaving at 5:30. So you can do it. So you can control whichever avenue you want. It just depends on what you want and what your demographic is. My demographic is predominantly single tooth dentistry all the way to full arch or digital dentures. I 3D print my own prototypes for my dentures, my monoblock try-ins. I outsource my iVotion manufacturing of the denture. So you can pick and choose and in-house or outsource whatever you want. And I mean, again, it's just a matter of how strong your solid foundation is. And as far as streamlining, I mean, I can design a crown in, 3 minutes. So it really just depends on what you want to do.
I love it because I think the biggest misnomer is that the foundation has been left behind. Actually, the biggest misnomer is you can do this without the foundation
Listen, man,
of the analog.
Listen, dental schools, if dental schools are getting rid of dental anatomy,
Yes.
I mean, that's like the biggest
We're in
mistake.
trouble because if you're doing designs in between hygiene, how much slower are you going to be, or how much more reliance on AI?
But not even that. Imagine if somebody comes and they fall and trip on the curb and they break number 8.
100%.
You're going to tell them, oh, sorry, you avulsed number 8. I'm going to take my scan today. I'm going to take my CBCT, and I'll see you tomorrow for number 8 guided surgery. And I'll have a prototype of with wings made for you for the temporary. Like, how about, like, the kid is 15, he's crying or whatever, you know what I'm saying?
Yep.
And remember the patient, and remember that you're still a dentist, and you need to know how to freehand the number 8 central incisor.
Right. Yep.
And sometimes digital technology, because of just the way you're designing and manufacturing, takes a little longer. You got to just do it and treat the patient. And so I think anyone who says skip the traditional fundamentals, I think they're just either naive or they're just lying to you.
Well, these weekend courses and things that, skip right through. Let me show you how to do digital. It's neglected the knowledge that we've learned that causes us along the way to make checks and balances and really evaluate even these new techniques.
Well, the thing is that every technology has a certain limitation.
That's right.
And it's always going to be, especially the more complex you do, there's always going to be a problem. And you always fall back, I don't know about you guys, but for myself, you always fall back on your traditional techniques to overcome that limitation or that problem.
Yeah.
And so you can do guided surgery all you want. God forbid you don't get stability. You better know how to analog place an implant, right?
Yeah.
So, or like I told you today, limited opening.
Yeah.
You plan all this stuff for full
Right.
arch. You put a 12 millimeter on number 3. All of a sudden the patient can't open that much.
It's so true.
Yeah.
I mean, and knowing that foundation is allowing us to be, and even in the labs, as you know, there's big issues in the labs as well with this, because they have these young technicians sometimes who, again, very, very comfortable with the video game world and digital world, but they don't know how to make a tooth. They don't know what a tooth looks like.
Yeah.
And so but let's talk about the advantages of what we're able to do in that digital workflow, though.
Okay.
So what can we do with that we can't do with analog? Let's talk about some of the things like we're seeing in people that say come in for, if you do a case, say, with photogrammetry. Let's just use that as an example because it is a sexy topic and people are talking about it.
Sure.
Talk about some of the things that allows you to do even as you go toward the definitive prosthetic, and even as you go toward like a prototype, that maybe allow you to eliminate some steps with some of the pre-planning that you do from the beginning. Are there things with that you're finding that your final or your prototype, it's easier to get there, or are you still finding that you're having the same amount of time and steps at the end?
Yeah. So with photogrammetry, right, there's 2 avenues. There's the immediate load photogrammetry workflow, and then there's the phase 2 when everything heals workflow. I'm more of an advocate of the phase 2 for it. I like to have a prefabricated prosthesis the day of surgery just for time and patient management, but also for just efficiency in our hands at least. But photogrammetry, I think today, is probably the most precise digital acquisition of full arch implant positions. Like, there's nothing that can compete with it if you're really trying to compete with it as in like numerical numbers of precision, right? When it comes to clinical significance, everything works, so it doesn't really matter. But as far as like who has the lowest microns, I think photogrammetry, based on the science and literature, has shown to be the most precise. So what does that mean? Well, that means if we're going in a generation towards tie-base free, or we're going towards metal free and zirconia monolithic direct 2 with a Rosen or a Vortex or a other screw, then you better have the utmost precision at your impression step to get it to fit on those SRAs or those multi-units, right? So as far as skipping a step, I wouldn't skip the verification jig, even though I have friends that talk about skipping verification jigs. Listen, I joked about it at lunch today, was if you're part of a DSO or if you're part of a university, you can skip all you want because you're protected by that entity, right? But if you're a small business owner and you're charging X amount and you're paying a lab bill that's X amount, and God forbid something breaks, where's your quality control? Who are you blaming? It becomes a finger pointing test of like who's at fault. And at the end of the day, you're going to eat up another remake of that prosthesis without knowing where the error happened. So I like a quality control step. But some people, to answer your question, would say photogrammetry, because it's so precise, you can skip that step, and now you can go to 2 appointments from boom to acquisition to delivery of the final, or go ahead to delivery prototype, then final in 3 appointments.
Let's say that you choose photogrammetry. That's step 2, that phase 2 prosthetic acquisition of the implants in the full arch situation, and you go ahead and you show it exactly what you did today. You've got cylinders with a stone, right? Which I love that, and I think that's cool. You showed another one was acrylic and talked about the thickness of that. you don't have a model at that point. And so if one doesn't fit, what are you doing at that point?
Yeah. So
if it doesn't verify,
yeah. And what's interesting too is a guy in France he came by to my office and he told me in France, I don't know how true this is, you can mill stone now. So imagine you could be fully digital by getting your photogrammetry implant positions, still stay in the CAD software and mill stone verification jigs instead of the way to make stone. The way to make stone now in the U.S. at least, and what I've learned is you manufacture a prototype. You backpour that prototype, you have a model very quickly, and then you make a verification jig off of that, right? So is that truly verifying the impression that's digitally acquired? Not really. You're verifying the printed or the milled prototype, right?
Yeah.
And so so that's that route, right? As far as answering your question of if the verification jig fails, which doesn't happen often, knock on wood, but if it does, theoretically, you're supposed to go ahead and section that crack that you see, right? Section it with as thin as you can. The soft, thin disc, you're not supposed to have a 3 millimeter gap. You're a thin disc, and if it's stone, you relute it with stone. If it's acrylic, you relute it with a lowest polymerization shrinkage resin. And then you can do two things. You can go back to your analog world and take a pickup impression. You can go back to your analog world and backpour that verification jig and have a new master cast made with a new verification jig. You can, if you want, reverse scan that verification jig that's intraorally picked up, and then now just cross-mount that with the RevX scan bodies from the, you know what I'm saying? Or the titanium cylinders or what have you, right? So there's multitude of ways to digilog it, if you will. But I agree.
It's a very different world, though, when you're not working with a model and you're having to think about these things. It's not bad. It's just different. Where I'm seeing it being really beneficial is we have a lot of patients who come in that need
beneficial of having a model?
Beneficial of something like photogrammetry or digital is with patients that we're retreating. You know, these patients that are coming in with an existing prosthetic with maybe one implant that's failed or maybe multi-units that are the wrong dimension, the wrong angulation. You're having to come in and to try to provisionalize those patients often is so challenging when it's analog. The fact that we can go in, we can take off the prosthesis, we can switch out the multi-units, we can get either photogrammetry or use a scanner. And then the next day or that same day, we can pull that off. I mean, that's something that I'm sure you're probably doing more redos these days. And that's where that technology, I think, versus impressioning and wax trims and aesthetic trying and going through. If you have something that looks decent, at least aesthetically, we can start to reverse engineer things.
I don't know who your audience is, but if they're younger, I don't want them to hear that because I think you learn a lot from doing all of the steps you just talked about traditionally. You know, I mean, yes, it definitely is a nice tool to have to make your life easier, but I think they have to learn the old school way.
I love it.
You know? I love this.
If you take that home from today, we've said that how many times?
Well,
I mean, this is not the focus. The focus is on learn the tried and true.
I was just reading a book on complete dentures because I'm a geek like that. And written by Doug Benton, and it was just. He said that in the very beginning. He said, I want to stress the importance of not skipping steps. And he said, in my opinion, the minute that we start eliminating steps from the complete denture process is the minute that we start reducing the consistency and predictability of our outcomes. Just one removal of one thing. Right? And I think the whole thing is like fast, do it quicker, more efficient. I called John the other day and I said, what are you charging for hybrids these days? And he was like, what are you charging? He was like, man, if you can get it, get that. Or if he was like, this is where I'm at. And he's like, I guess I'm just so efficient. And I'm sitting here thinking, well, I'm pretty efficient too. What are you doing differently that I'm not doing? You know, from that standpoint. And I think that's the thing is like small business is what we all are running here, right? And that's what we have is we have a small business where one decision could impact, you know, the outcome. And I think the lab makes it such a big deal about this. They're like, oh, I can just mill you another one. I can just mill you another one. But who's paying for that?
Yeah, but even just like the hour, seeing that same patient that's broken it 3 times or had the 8th prototype.
You don't even want to walk into the room.
The staff gets irritated, right? When they see the name on the schedule, right? So like, it's like, yes, you can mill me another one for $800. I appreciate it, but just the headache that goes with it makes everything not worthwhile, no matter how cheap it is.
True. So true.
Well, I love it. This has been great conversation. I knew it would be, and I think, you know, that if you're listening to this, you know, and you're, first of all, why aren't you here, right? Number one, because you should be here and you should be taking advantage of these conversations with people that are at a high level. But I think, the fact that we can take the old and the new, and we can really say, we can't forget the old. And I love that. I think it's really, because the subtext of this meeting is making it easier. But in the end, that's what makes it easier. Yeah. It's not necessarily all the new technology. It's not necessarily the sexiest of things. It's like we can use these tools, but we really appreciate your approach to that, because I think, like you say, the old and the new kind of coming together.
I mean, dude, the thing we joke about is my dad coined like Digilog, right? It's like taking the best of both worlds. Whatever that works in the digital world, knowing the limitations, and then embracing the analog foundation to make it predictable for our patients. At the end of the day, that's all that matters, right? Can I go ahead and treat my patient with the utmost precision in the least amount of appointments for me and for the patient's journey, right? And so today, as far as reaching a 100% modelless workflow for full arch, some people will argue yes. I'd say that yes, I showed you a couple today. Do I do that for every single patient? No. And really, it's just patient dependent, and also, a lot of other factors. So fall back on your traditional techniques and have a good foundation, and then God knows 8 years from now when I see you again and you have to come here, we're going to have a whole different conversation.
We're going to have to make that
a little bit more than 60 years.
Yeah, exactly.
Yeah.
I think one of the things that is if you're listening to this and you're looking to get into a full arch workflow, if you're not doing it every day, I think the take-home message here, John, is let's not jump to the nth degree, the bleeding edge immediately. Let's learn the foundational steps that have been predictable, like you said, 20, 30 years.
Who are we to argue that doesn't work?
Right. Even I told John, I still today cut holes in dentures and do conversion prosthetics.
I said today, I still use step one, right?
I still use step one.
Why not?
Why not? It's tried and true, and in some ways it's like, I don't have to worry about the patient coming back tomorrow, because they're going to be hurting tomorrow, and they want to be numbed up again tomorrow. And so, like, if you're listening to this, the foundations are key, and it just keeps coming back.
And to be real, there's a learning curve for everything. Okay, it doesn't mean all of a sudden reverse scan. Here I am trying to show you how easy it is on the screen. There is a learning curve of how to do it.
Are hard,
and then even with the new Exact, right? When I showed you splinting them, I mean, we have my friends that are like the professional scanners, they had trouble. So like, it doesn't mean that it's a magic bullet. It's gonna omit all your errors and all your troubles, and you're gonna have a 20-minute appointment with your patient. There's gonna be a learning curve. And at the end of the day, it's just a matter of.
And so again, if you're one of those, we started the conversation with, talking about Instagram, right? You show the before and show the after. What we're talking about here is the real deal, the stuff behind the scenes, all the unseen steps.
You guys are one of my first followers, if you will, on Instagram. And the funny thing is, I've slowly, every Instagram has their own little, you're either a direct-to-patient Instagrammer with before and afters. I'm more of an educator. Like, this is the rationale of how I did these steps. And it's changed because lately I've been showing a lot of course, like, this is how I did a reverse scan or photogrammetry, but I'm showing a lot of, like, troubles that I'm going through. Because that's real life dentistry, but I'm showing it with digital, right? So it's like, it doesn't mean that, and Instagram, I mean, I'm still saying post your stuff. I'm still, share it. It's a community. We're all learning. But don't be naive thinking that all this stuff is
right.
It's not easy.
Even what I say, it's not that easy.
It's not that easy.
Well, thank you once again for being with us.
No
we
problem,
really
man.
appreciate it. And for those who are watching, definitely go. If you're not already following Dr. Bedrossian, check him out. He's got some great stuff on his social media. And if you see him obviously on the lecture circuit, go hear what he has to say.
Appreciate it.
Thanks once again to the Academy for having us here, and we'll let you get back to your day. So for Armand, for Wes, I'm John, and we are the Dental Guys.